Welcome. I am Marlene Marino, one of the instructors here at UMA. In our course this week, we're discussing managed care. So in this presentation, we will cover the terms related to managed care, its history, including major developments in the United States from 1973 to the present, so to now, along with 6 managed care models and also consumer-directed health plans. We will also identify the accreditation of managed care organizations and the effects of managed care on a physician practice. So follow me. Currently, more than 70 million Americans are enrolled in some type of managed care program, and this in response to regulatory initiatives affecting healthcare cost and quality. So what managed care is a healthcare delivery system that is organized to manage cost, utilization, and quality. So in other words, it was developed as a way to provide affordable, comprehensive, prepaid healthcare services to enrollees or beneficiaries of these plans. So again, they were organized to manage several things, but 3 that I mentioned: cost, utilization, and quality. So provide affordable, comprehensive healthcare services. So let's take a look at its evolution. So as you can see here, we're going to go all the way back to 1973. And in 1973, we have the Health Maintenance or HMO, Organization Assistance Act of 1973. And what this particular act did, it authorized grants and loans to develop HMOs under private sponsorship. It also required most employers with more than 25 employees to offer HMO coverage if local plans were not available. Then in 1979, we had the creation of ERISA, or the Employee Retirement Income Security Act, again of 1974. And what this act did, it mandated a reporting and disclosure requirements for group life and also for health plan, and this also included managed care plans. Okay, it also permitted large employers to self-insure employees' healthcare benefits, and it exempted large employers from taxes on health insurance premiums. Then in 1981, we have OBRA, O-B-R-A. This is the Omnibus Budget Reconciliation Act. And what this act did, it provided states with the flexibility to establish HMOs for Medicare and Medicaid programs. In 1982, we had the Tax Equity and Fiscal Responsibility Act. And what this act did, it actually modified the HMO Act of back in 1973. Again, this is in 1882, it modified the 1973 HMO Act. And what it did, it created Medicare risk programs and defined risk contract and competitive medical plans as an HMO that meets federal eligibility requirements for a Medicare risk contract, but it's not licensed as a federally qualified plan. Okay, so this is back in 1982. A couple of years later, in 1985, we have the Preferred Provider Healthcare Act. Yes, our PPO. So what this act did is it eased the restrictions on preferred provider organizations, or PPOs. It also allowed subscribers to seek healthcare from providers outside of the PPO. We also had in 1985 the creation of COBRA. So in 81 we had OBRA, now we have COBRA in 1985. So this is the Consolidated Omnibus Budget Reconciliation Act, and what did, it established an employee's right to continue healthcare coverage beyond the scheduled benefit termination date, and this also included HMO coverage. Okay. Then in 1988, there was another amendment to the HMO Act. So from 1973, it was created in 73. In 82, it was modified. In 88, it was amended, and it was amended to allow federally qualified HMOs to permit members to occasionally use non-HMO physicians and be partially reimbursed. Okay, so very important. Then in 1989, we have HEDIS, or HEDIS, which is the Healthcare Effectiveness Data and Information Set. This was developed by NCQA, or the National Committee for Quality Assurance. And what this did, it created standards to assess managed care systems in terms of membership, utilizations of services, quality, here's quality again, access, healthcare management and activities, and also financial indicators. So very important. This is HEDIS from 1989. Standards for membership, utilization, quality, access, management activities, and financial indicators. Then in 1984, we have the Office of Managed Care, and established as an office of HECFA, or the Healthcare Finance and Administration, which that's what it used to be called back then. But now we call this CMS, or the Centers for Medicare and Medicaid Services. So they established this office to facilitate innovation and competition among Medicare HMOs. Okay, so this is the Office of Managed Care. Then in 1996, guess what was created? Yes, you guessed it right. HIPAA, H-I-P, two A's, guys, not two P's, two A's, the Health Insurance Portability and Accountability Act. It created standards for insurers, HMOs, and employer plans, including those who self-insured. So once again, HIPAA of 1996. Then in 1997, we had several developments. So please bear with me. So the first one is the Medical Savings Account was created. And the Medical Savings Account, known as MSA, is what we now call HSA, or a Health Savings Account. And what this does, it allows individuals to withdraw tax-free funds for healthcare expenses that are not covered by qualifying high-deductible health plans. So again, we know these as HSA, or Health Savings Account. Another development in 1997 was the Balanced Budget Act. And what this did is that it encouraged the formation of primary provider service networks, or PSN, and provider service organization, or PSOs. It also established Medicare Plus Choice programs. So what this did is it expanded Medicare coverage options by creating those managed care plans. So we know this as our Medicare Part C, or Medicare Advantage plan. So once again, it expanded Medicare coverage options by creating this managed care plans to include HMOs, PPOs, and MSA, or HSA, which now once again we call this the Medicare Advantage, or Medicare Part C. And it also required organizations to implement a quality assessment and performance improvement program so that quality assurance activities can be performed to improve functioning of these Medicare Part C, or Medicare Advantage organizations. So that happened in 97 also, but we have one more. So in 1997, listen to this, guys, Texas became the first state to enact legislation allowing consumers to sue an HMO for medical malpractice. So that also happened in 1997. So we had the Health Savings Account, the Balanced Budget Act, which created Medicare Part C, or Medicare Advantage, and Texas becoming the first state to allow consumers to sue an HMO for medical malpractice. Then fast forward to 2003, we have the Medicare Prescription Drug Improvement and Modernization Act. So now we're talking about Medicare Part D. So this was amended, it amended the Internal Revenue Code of 1986 to allow the deduction to individuals for amounts contributed to health savings accounts. Okay. and health savings security account, and also to provide for the disposition of unused healthcare benefits in what we know as cafeteria plans and flexible spending. It also flexible spending arrangement. It also renamed that Medicare Plus Choice program from Medicare. It renamed it to Medicare Advantage. So that's kind of where the name change happened, which we also call Medicare Part C. It established the Medicare prescription drug benefit, Medicare Part D, and it also established that health savings account. So this is where that also the other name change happened from MSA or medical savings account to health savings account or HSA. Fast forward to 2016. I know that was like a really big jump from 2003 to 2016, but the 21st Century Cures Act requires the submission of a report on the risk adjustment model and end-stage renal disease risk adjustment model under Medicare Advantage program every 3 years. So this is what it is. So risk adjustment, what it is a method of adjusting capitation payments to health plans, accounting for differences in expected health cost of enrollees. So commercial insurances, they determine the revenue needs based on the trends in medical expenditures, benefits offered, and anticipating enrollment. And then they determine how to set the premiums, the deductibles, co-payments, and co-insurance amounts. On the other hand, the Medicare Advantage risk adjustment model are a little bit more comprehensive in that diagnosis and the demographic information are also used to adjust each enrollee's monthly capitation rate to account for expected cost associated with age, gender, and condition. At the individual level or enrollee level, predicted medical costs can be lower or higher than the actual medical cost. At the group of enrollees level, below average predicted cost balance out the above average predicted cost. So this is where your risk adjustment is intended to be a little bit more accurate at the group level. So a lot of history, guys. History shows us where we came, what we've done, and it kind of gives us a little bit of a glimpse towards the future. Okay. So managed care originally focused on cost reductions by restricting healthcare access through utilization management and availability of limited benefits. Managed care organizations or MCOs were created to manage benefits and to develop participating provider networks. And we hear that a lot when we're talking about our doctors and are they participating, non-participating, are they in a network, are they out of network? So we'll hear those terms a lot. Managed care can now be categorized according to 6 different models. And these are the models that you're able to see on your screen. So we have the exclusive provider organization or EPO. This is a managed care plan that provides benefits to subscribers who are required to receive services from network providers. So in network. Usually network providers sign exclusive contracts with the EPO, which means that they cannot contract with other managed care plans. Okay, so that's very important to know. Subscribers, as those are your patients, your members, are generally required to coordinate healthcare services through their primary care physician. So they have to have a PCP. Primary care physician, primary care provider, gatekeeper, those are all the words for PCP. Now, something to note about the EPOs is that patients must receive care from participating providers, which can include emergency departments at participating hospitals, or, listen to this, guys, or they will pay for all costs incurred. So everything that they incurred, all the costs, all the balances, they would have to pay for that if they were not seen from a participating provider. The next one that we have on here is the Integrated Delivery System, or IDS. This is an organization of affiliated provider sites, such as hospitals, ambulatory surgical centers, or physician groups. And what they do is they offer joint healthcare services to subscribers, members, patients. Models include physician hospital organizations, management service organizations, group practices without walls, integrated provider organization, also medical foundation. So something to note about IDS or integrated delivery system, this is the result of a joint venture between hospitals and members of their medical staff is usually what you would see this type of plan. The next one that we have is, you have seen this term before, have heard it before, but it is HMO, a health maintenance organization. And this is an alternative to the traditional group health insurance coverage. And it provides comprehensive healthcare services to voluntarily enrolled members on a prepaid basis. HMOs provide preventive care services to promote wellness or good health, which what that does in turn is that it helps in reducing the overall cost of medical care. For HMOs, guess what you need to have? Yes, you guessed it right. A PCP, so a primary care provider, is assigned to each subscriber to be responsible for coordinating the healthcare services and referring subscribers to other healthcare providers. So that's also why they're called the gatekeepers. You know, they can open the gates and let you see other providers and other specialties. So they might say, no, I can go ahead and treat you for this, and you are good to go. We also have point of service. So some HMOs and preferred provider organizations have implemented what we call a POS plan, or point of service plan, under which patients have freedom and flexibility to use the managed care panel of providers, or they can self-refer out to out-of-network providers. So there is that flexibility. Now, something to keep in mind about the POS plan, this is not an HMO. It is not an HMO. So I'm going to say that one more time. A POS plan is not an HMO, but it is a managed care plan that combines characteristics of an HMO and some characteristics from the PPO, or preferred provider organization. POS enrollees pay less if they use the in-network providers. POS enrollees who receive care from an out-of-network provider are going to have to pay higher deductible and coinsurance amounts. So they can see outside of network, but their out-of-pocket expense will be higher. Okay. The next one that we have on here is the preferred provider organization, or PPO. Sometimes we call this participating provider organization or preferred provider organization. So you hear it being called both ways. This is a managed care network of physicians and hospitals that have joined together to contract with insurance companies, employers, or other organizations to provide healthcare to subscribers for a discounted fee. So PPOs do not routinely establish contracts for laboratory or pharmacy services, but they do offer a reduced rate contract with specific hospitals. So keep that in mind. Most PPOs are open-ended plans, allowing patients to use non-PPO providers, once again, in exchange for a larger out-of-pocket expense. Premiums, deductibles, and co-payments are usually higher in a PPO plan than those in an HMO plan, but lower than those for from your regular fee-for-service type plan. So something else to note, a PPO is not an HMO. It is similar because it is a managed care plan that provides enrollees with discounted healthcare through a network of providers. But PPOs enrollees can also receive care outside of the network if they're willing to pay for higher cost. So that's the difference between your HMOs and your PPOs. The last managed care category that we have is the triple option plan. And this is usually offered either by a single insurance plan or a joint venture among two or more insurance payers, providers, subscribers, or employees with the choice of HMO, PPO, or traditional health insurance. This is that plan that I said a little bit earlier we called a cafeteria plan, because it's a flexible benefit plan. That's also another option because of the different benefits that there are and the extra coverage options that are provided through the insurer or a third-party administrator. So something to note about the triple option plan is that it provides patients with more choices than your traditional managed care plan. So those are the 6 managed care categories that we have. Another one that we have here are the consumer-directed health plans. So these are defined employer contribution and ask employees to be more responsible for healthcare decisions and cost sharing. So you might think of these type of plans, the consumer-directed health plans, as sort of like a 401k. Okay, so this is the 401k plan for healthcare. So it's recalling the shift from employer-defined benefit pension plans to employer-defined contribution 401k plans. So our consumer-directed health plans include many choices that provide individuals with an incentive to control the cost of health benefits and healthcare. Also, individuals have greater freedom in spending healthcare dollars up to a designated amount. So more freedom, but you do have a designated amount, and receive full coverage for in-network preventive care. So what do we get in return? So in return, individuals assume significantly higher cost sharing expenses after the designated amount has been expended. So once you spend it, you're going to have higher cost sharing expenses. Okay. These plans have become a popular alternative to the increased cost of traditional health insurance premiums and the limitations that are associated with managed care plan. They do have different tiers. Okay, so there are 3 different tiers. They have, the first one is tax exempt account, which is used to pay for healthcare expenses and provides more flexibility than traditional managed care plans. This is in terms of access to providers and services. Number 2, out-of-pocket payments for healthcare expenses, which are made after the tax-exempt account is used and before the deductible for high deductible insurance has been met. So this tier usually represents like some sort of gap coverage or a gap in coverage. Then the last one, we have the high deductible insurance policy, which reimburses allowable healthcare expenses after the high deductible has been paid. Okay. And you do have 5 different types with those 3 tiers. Now on to accreditation of organizations. So the NCQA, or the National Committee for Quality Assurance, what they do is that they evaluate managed care organizations. So the accreditation process is a voluntary process that a healthcare facility or organization like your hospitals or managed care plan, they would undergo to demonstrate that they have met the standards beyond those required by law. Once again, accreditation is voluntary, 1, and what they're doing is they're demonstrating that they have met the standards beyond those required by law. So they've gone above and beyond, not just what is required by law, but beyond that. The accreditation organizations develop standards or requirements that are reviewed during a survey or an evaluation process that is conducted both off-site, like in your managed care plan, they're going to submit initial documentation for review, and also they do it on site at the actual facility. The NCQA, or National Committee for Quality Assurance of Washington, D.C., it is a private, nonprofit organization that assesses, once again, the quality of managed care plans in the U.S., and not only do they assess this information, they release this data to the public. So it's out there for us to look at. So they assess the quality, they release the data to the public for consideration when selecting a managed care plan. The NCQA began accrediting managed care programs back in 1991 when a need for consistency, independent information about the quality of care provided to patients was originally identified. So the need was identified, they stepped in and said, we'll assess the quality, we'll release the data so that everybody can make informed decisions. Now, we also have HEDIS, which I mentioned earlier during our presentation. This is the Healthcare Effectiveness Data and Information Set. This is sponsored by them, by the NCQA, the National Committee for Quality Assurance, and it consists of performance measures that are used to evaluate managed care plans, like example, the rate of pap smears that are performed among women of a certain age, okay? So the NCQA reviews managed care plans, develops report cards to allow healthcare consumers, once again, to make informed decisions when selecting a plan. So the report card is going to contain data regarding the quality of the managed care plans, the utilization, consumer satisfaction too, administrative effectiveness, financial stability, and cost control. Very important. Managed care organizations do have a huge impact, guys. They have a huge impact on a practice administrative procedures because they have certain requirements that your offices will have to meet. And you might ask, what are those requirements? Well, here they are. The first one is to have separate bookkeeping system for each capitated plan to ensure financial viability of the contract. 2, a tracking system for authorization of specialty care and documented request for receipt of the specialist treatment plan or consultation report. 3, pre-authorization and or pre-certification for all hospitalizations and continuous certification if the patient conditions require extension of the number of authorized days. Number 4, up-to-date list for referrals of participating healthcare providers, hospitals, and diagnostic test facilities that are being used by the practice. Another list, number 5, that needs to be kept up to date is a list of special administrative procedures required by each managed care plan contract. Number 6, another list, up-to-date list of patient co-payments and fees for each managed care plan contract. Number 7, special patient interviews to ensure pre-authorization and to explain out-of-network requirements if the patient is self-referring. Number 8, additional paperwork for specialists to complete and the filing of treatment and discharge plans. 9, for some case managers that are employed by the MCO, they're employed to monitor services provided to enrollees and to be notified if the patient fails to keep a pre-authorized appointment. And lastly, number 10, the attachment of this pre-authorization documentation to health insurance claims that are submitted to the MCO or the managed care organization. So again, it has a huge administrative impact on the practices. So here are some important terms that we need to remember when we're dealing with managed care, just insurances overall. We need to know what a managed care is. Once again, they're responsible for the health of a group of enrollees. It can be a health plan, a hospital, a physician group, or a health system. Fee for service, what this does is a reimbursement methodology that increases payment if the healthcare service fees increases, if multiple units of service are provided, or if more expensive services are provided instead of the least expensive services. For an example, it's like your brand name versus your generic for like prescription medication. Another term is capitation. So capitation, this means the provider accepts pre-established payments for providing healthcare services to enrollees over a period of time, which is usually a year. This is your capitation payment. PCP, we've talked about it several times. Primary care provider, they're responsible for supervising or coordinating healthcare services for enrollees and also approve referrals to specialists and inpatient hospital admissions, with the exception of emergencies. We also talked about the quality assurance plans to assess quality of care provided in healthcare settings. The quality review organization, which is responsible for reviewing healthcare provided by managed care organizations. And I will tell you this, many states have laws that require an external quality review organization for these quality improvement systems. So the quality improvement system for managed care, this was established by Medicare. And this is to ensure the accountability of managed care plans in terms of objective and also measurable standards. Utilization management or utilization review. This is a method of controlling healthcare cost and quality of care that is implemented with managed care plans. Okay, so the utilization review organization, they established the utilization management program, and they're the ones that performed this utilization review services. Case manager, we've talked about it earlier, submits a written confirmation. Briefly, we talked about it. Authorization for treatment to the provider. These are the plans for the coordination and provision of care of complicated cases in a cost-effective manner. We have something called GOG clauses, and these are clauses that could be in those contracts. So what it does, it prevents providers from discussing all treatment options. Listen to this, guys. Prevents providers from discussing all treatment options with patients, whether or not the plan will provide reimbursement for services. So why would you have such thing? Well, I'm here to tell you that Medicare, and many states prohibit managed care contracts for having such clauses. Okay, so they exist. Once again, Medicare and many states prohibit the use of having this clause. So this is what it is. It prevents the doctor from telling the patient, okay, these are your different treatment options. So why wouldn't you want to tell the patients the different treatment options? Exactly. This is why this is prohibited by Medicare and many states. Now, we do have, on the other hand of that, physician incentive or physician incentive plans. These include payments that are made directly or indirectly to healthcare providers to serve as encouragement to reduce or limit services to save money for the managed care plan. Okay, so this is a lot of different terms and just a lot of information covered in this particular presentation. So our video lecture, the objective of our lecture today, or this video lecture, focused around managed care plan, its history, its makeup, and just all of the intricacies. So I know I just gave you guys a lot of information, but as you reflect on this topic and you are getting ready to do the work for the rest of the week, make sure to use this content. I know there was a lot that we covered. The materials on our readings, our weekly materials, the interactive on our course. And guys, if you need to do a little bit of research, make sure that you're using a reliable source to make sure that you're maximizing your learning. Just because it's out there in internet space doesn't mean it's 100% accurate. And a place that you can go to get started is your UMA library. We're also here for you, so please do not hesitate to reach out. You're not alone in this journey. Like I said, there was a lot of information that I just covered. So if you have any questions, if you need any help, please do not hesitate to reach out. We're here for you. Okay. Well, guys, thank you all so much for watching. Let's just go ahead and have a great day and have a great class.